Good morning, afternoon, or evening to the judges and participants of Sonobuzz 2026. The paper I will be presenting today is titled Fat with an Attitude, a case series exploring the role of ultrasound in epiploic appendigitis and omental infarction. My name is Dr. Tushar Sharan. I'm a third-year junior resident at MGA Medical College, Navi Mumbai. The inspiration for my study was based on a study done by Neeraj N and team. Out of the study, in 25 patients who had a confirmed diagnosis of epiploic appendigitis on CT, sonographic features were observed in only 8 out of 25 cases, which is 32%. So if epiploic appendigitis and omental infarcts are confidently picked up on ultrasound, we can avoid CT as well as unnecessary surgery and ultimately end up saving the patient a lot of money, resources, and time. Intraperitoneal fat necrosis comprises a group of benign inflammatory conditions involving adipose tissue within the peritoneal cavity. Among these, epiploic appendigitis and omental infarction are uncommon but important causes of acute abdominal pain. These entities are frequently misdiagnosed clinically as appendicitis, diverticulitis, or cholecystitis, leading to unnecessary hospital admissions, antibiotic therapy, or surgical intervention. Although CT is widely regarded as a reference imaging modality, ultrasound plays a crucial role as the first-line investigation in many emergency settings. Recognition of characteristic sonographic features allows confident diagnosis and appropriate conservative management. This study presents our experience with ultrasonographic evaluation of epiploic appendigitis and omental infarction in 10 patients. Aim to study the role of ultrasonography in diagnosing epiploic appendicitis and omental infarction. Our objectives are to characterize the lesions, to correlate with CT findings, and to emphasize the role of ultrasound in avoiding unnecessary surgical intervention. This was an observational case series. 10 patients with focal acute abdominal pain showing sonographic features suggestive of intraperitoneal fat necrosis were included in the study. The inclusion and exclusion criteria are as on your screen. The ultrasound technique predominantly involves assessing parameters such as location and size of lesion, echogenicity, compressibility, relationship to the adjacent bowel, presence of hypoechoic rim, Doppler vascularity, probe tenderness, and CT correlation and follow-up wherever available. Total 10 cases were studied, out of which 6 cases were diagnosed to have epiploic appendigitis, and out of these 4 cases consisted of omental infarction. Majority were middle-aged patients who presented with localized abdominal pain. Beginning with the first part of our paper, what is an epiploic appendage? As you can see on your screen, it is a small fat-filled pouch of visceral peritoneum that hangs from the tinea coli of the colon. So naturally, if we are looking for epiploic appendigitis, we will try to look for the bowel or the colonic wall that it is associated with. So beginning with a characteristic sample case of epiploic appendigitis, this is a well-defined ovoid hyperechoic focal lesion seen. This was actually in close relation to the sigmoid colon. It is non-compressible. It has a small, it can sometimes have a hypoechoic rim, which we'll see in the next case, absent internal vascularity and probe tenderness. This is the CT of the same case. We can see that there is a fat attenuation ovoid lesion adjacent to the sigmoid colon with surrounding fat stranding. The hyperattenuating peripheral rim is the ring sign. No evidence of any other complications is seen. This is the same patient with the coronal image showing the same findings. I would like to stress upon the fact that although classically described as a hyperechoic lesion, the echogenicity of subacute epiploic appendigitis may appear heterogeneously hyperechoic to hypoechoic. So as you can see in the diagram, this is an inflamed epiploic appendage, which is a little heterogeneous relatively, and it is closely associated with the sigmoid colon. This is what we are trying to see here. Coming to the next part of our study, what is omentum? It is a adipose tissue structure arising from the greater curvature of the stomach, which hangs below inferiorly like a curtain and serves more of a protective function. Omental infarction, it is a larger ill-defined heterogeneous hyperechoic mass lesion, predominantly right-sided, non-compressible, no vascularity, and no other associated bowel features. In this particular case, we saw that there was focal thickening of the peritoneum, which suggests inflammatory changes. And in some very rare cases, like the one we picked up, there was a linear hyperechoic structure corresponding to a thrombosed vessel on CT. As you can see, the CT points to a dot. And over here, we can see the linear nature of the structure, which is the thrombosed vessel, which we picked up even on ultrasound. So we suggested the same in our ultrasound report, and the findings were confirmed on CT. CT will show a heterogeneous fat attenuation ovoid lesion with surrounding fat stranding. CT imaging available in most cases confirm the diagnosis as on ultrasound, and all patients are managed conservatively. The key feature being here that epiploic appendicitis and omental infarction, if picked up on ultrasound, avoid unnecessary CT and unnecessary surgical intervention, because these diseases are relatively managed conservatively, and the most you will need is analgesics and anti-inflammatory medications. Epiploic appendicitis and omental infarction represent two ends of the spectrum of intraperitoneal fat necrosis. They result from torsion or venous thrombosis of the epiploic appendages, while infarction is due to vascular compromise of the greater omentum. Ultrasound findings of hyperechoic, non-compressible fat lesions with absent vascularity are characteristic of both entities. Recognition of these features, along with focal probe tenderness and lack of bowel wall changes, allows differentiation from surgical causes of acute abdomen. Although CT provides a definitive diagnosis, ultrasound offers a radiation-free, readily available modality that can guide appropriate conservative management when characteristic findings are present. The limitations of my study were, of course, smaller sample size, retrospective nature, and CT correlation. Although available, it's not provided in all cases. My conclusion would be that epiploic appendicitis and omental infarction are important benign causes of acute abdominal pain that can be reliably diagnosed on ultrasonography. Awareness of the characteristic sonographic features enables early diagnosis, prevents unnecessary surgical interventions, and reduces dependence on CT imaging. The take-home message is as follows: not all acute abdomen needs surgery or CT. Pattern recognition on ultrasonography can confidently diagnose intraperitoneal fat necrosis. These are my references. Thank you. Thank you for a patient hearing.